My name is Dr. Rafi Kevorkian. I'm a geriatric specialist, and I would like to discuss with you a presentation on the practical approach to delirium. The objectives for this lecture are going to be: why is delirium a big deal? Number two, how common is it? We're going to discuss risk factors. We're going to try to differentiate delirium from dementia. We're going to look at the causes, and we're going to discuss how to take care of a confused delirious patient. Most importantly, you need to recognize that delirium is a very dangerous diagnosis. Delirium is associated with increased complications within the hospital setting, such as falls, pulling out catheters, pulling out IVs. It also increases the likelihood that a patient will be placed in a nursing home and lose their independence. It will prolong hospital stays from a typical 3 or 4 day hospitalization to maybe a 7 or 8 day hospitalization. It will cause or lead to loss of function and loss of the ability of the patient to perform their activity, daily living functions, and it also will increase mortality. Delirium is commonly present upon admission. Roughly 20% of the patients will present with delirium to the hospital setting. Another 30 to 35% will develop delirium while in the hospital, but roughly about 50% or so will not be recognized as having delirium, which causes delay in diagnosis and loss of function for the patients. Delirium can present in 3 different ways. It can present as the agitated patient who is climbing out of bed, pulling at the IV, screaming, hallucinating, having paranoid thoughts, trying to pull the catheter, versus the hypo-alert patient that is you're having trouble arousing, and then combination where in the early part of the day the patient may be agitated, then they're asleep, then they're agitated again. Roughly 75% present in the agitated state, and another 25% present in the hypo-alert state. On this slide, we will discuss the DSM-4 criteria for delirium. The hallmarks are the sudden onset, the disorganized orientation, the inattention, and the psychomotor agitation and lethargy. Remember that every fall should be considered a delirium equivalent and not just an accident. The delirium pathophysiology is felt to be multifactorial, with alterations in cytokines that reduce cerebral blood flow that can lead to the hypo-alertness or the agitation, with alterations in increased anticholinergic activity and glucose metabolism in the brain. Keep in mind that delirium is not the same as dementia, although having dementia will increase your risk of developing delirium. So why should we differentiate between dementia and delirium? The reason for that is most patients that develop delirium have over 90% of them have a reversible cause and will do better, whereas in dementia only 10% will have an improvement or have a reversible cause. With delirium and dementia, you need to remember again that delirium has a sudden onset that can fluctuate as the day goes by. There's this organized thought, and the patient's typically distracted, versus a demented patient who has a chronic onset of their memory impairment with a slower decline. They usually have disoriented thought process and usually are not distracted at all. This slide uses a simple mnemonic that's been published in the literature called Deliriums. It's to help you figure out what could be causing delirium. A lot of times when I'm in the office setting or the hospital setting, I will do a checklist and see if there's anything that I can find on clinical exam or observation. The D is for drugs. Many drugs can cause delirium, whether they've been recently started, meaning there's a temporal factor where a drug was started a week prior to admission and then it led to the confusion, such as Benadryl, hydroxyzine, versus drugs that the patient is on that can cause delirium, such as amiodarone, the diabetes drugs, lithium with lithium toxicity, the Jackson and the Jackson toxicity. So you need to pay attention because drugs are one of the largest, most common causes of delirium. The E is for emotional depression. Commonly in the psychiatric ward you will see major depression with psychotic features presenting as delirium, where the patient may think people are going to kill them, or they've had delusions of infidelity or theft. Next, the L, anything that causes or affects the oxygen states, that causes hypoxia, whether it's a CHF exacerbation, COPD exacerbation, pulmonary embolization, anemia, sepsis. Next, I is for infection. Any infection can cause delirium, whether it's an abscess, sinus infection, meningitis, pneumonia, urinary tract infections, cholecystitis, diverticulitis, cellulitis. Next, the R is for retention, for urine and stool. You would do a good history on voiding to see if the patient's obstructed, where you may have to insert a catheter or perform a post-void residual, or if they're impacted with stool from medicines that cause constipation, or there's an actual obstruction in the intestinal tract. The I is for ictalosseizures, which is a very difficult diagnosis to make. As you can see in the insert, it can take up to 1.7 years to diagnose. It's commonly mixed. Next is the U for underhydration or dehydration and malnutrition or undernutrition. You see the insert there with the gentleman with severe muscle wasting and so forth. Next, metabolic disturbances such as hypohypernatremia, hypohypercalcemia, hypohyperkalemia, hypohyperthyroidism, and then last but not least, the S is for subdural. So a typical workup would be to do a CBC, complete metabolic panel, a TSH, chest x-ray if there's a reason to suspect a pneumonia, an EKG, possibly an abdominal x-ray or CT scan of the abdomen, possibly a head CT if you suspect a stroke or a subdural bleed. In addition, you may need to obtain a urine analysis with culture as well as a set of blood cultures. Keep in mind that restraints, which were very common 10, 15, 20 years ago, have been shown to cause more harm than benefit. Isolated cases may be ventilated patients that are trying to remove their intubation tube that may need to be restrained. Otherwise, sitters can be obtained for these patients. Keep in mind that a Foley catheter is considered a one-point restraint. So delirium, there are so many risk factors that could cause delirium. As such, every patient needs to be screened either in the clinic setting, nursing home setting, or hospital setting if confusion is suspected. Keep in mind that antipsychotics, which are commonly used for delirium or the management of delirium, can increase mortality rate. One common treatment for the confused delirious patient is what we call the delirium room. The delirium rooms are considered restraint-free environments that have been shown to possibly decrease mortality. As you will see an insert of the delirium room, where it's a open room with 4 beds, typically 1 nurse and 1 aide that can manage 4 patients versus having them separated and spread apart throughout the hospital setting. A study of the delirium room was performed at St. Louis University that compared patients in the room versus patients in the geriatric unit, what they call the acute care of the elderly, or ACE unit, in which they were able to match and control 51 patients. You can see the baseline characteristics with the average age roughly matched. Most of the patients were female, had similar DRG length of stay scores based on their hospital admissions. On this slide, there were no significant values in expected length of stay or actual length of stay, but there was a trend towards decrease in cost of the care of the patient. See in this slide, patients who had delirium had worsening function and ADLs upon admission, and that persisted upon discharge, whereas patients who did not have delirium had improvement in their function upon discharge. As you can see, drug use to help calm or sedate these patients was minimal, with only 8% receiving antipsychotics, 12% receiving benzodiazepines, and 6% receiving both. So roughly about 26% of the patients received any sedative to help calm them down. As you can see, the hospital is a dangerous place because of the multitude of things that can cause delirium and worsen outcome for the patient. In this slide, the important question is, should the patient be sedated or not? This is going to depend on your clinical experience and whether the patient has had a head injury or not, is on a ventilator or not, and the short-term benefit that the patient may get till the delirium is improved. Some patients absolutely do need sedatives, and then within the next 2 to 4 weeks will not require them because the cause of the delirium has resolved, and then as such they must be stopped. I commonly see a lot of patients that come out of hospitals that have been on antipsychotics for 2, 3, 4 months that should have been discontinued, and will fall and receive injuries such as hip fractures. You got to remember that 90% of the cause of delirium will resolve within a month, and the need for these antipsychotics is no longer required. In this slide, delirium is associated with increased mortality. Many studies have shown and have predicted the increased mortality. In a study in which 214 nursing home patients were followed for 3 months during and after acute medical hospitalization, the mortality rate in the in-hospital setting was 18%, and the 3-month mortality rate was 47%. The greater the severity of delirium on admission, and the slower the progress or the improvement of the delirium, will lead to increased mortality. The incidence of mortality from delirium ranges from 25 to 33%, which is as high in comparison with an acute myocardial infarction or sepsis. In this slide, you will notice the incidence of patients that had delirium when they were discharged from the hospital, and then they were followed for up to 6 months to see whether delirium persisted or not. In the first study from Levkov, you notice that there was 96% of the patients had delirium on discharge, and that 82% had persistent delirium. In a study by Marcantonio, the incidence of delirium upon discharge was 39%. It was 32% after 1 month, and then 6% at 6 months. In the study by Kelly, you notice also a trend towards lessening in delirium. This slide shows you the incidence of delirium present in patients that went to skilled rehabilitation. You see that of those that were admitted to the rehab setting, that after 1 week, 14% resolved, 22% had fewer symptoms, 52% had the same symptoms, and 12% got worse. Patients that had same or worsening symptoms had worsening function in activity daily living and instruments of activity daily living. In this slide, studies were done looking at the prevalence of delirium in the nursing home setting. So what the researchers did here is that they walked through the nursing home from patient to patient, and then they just assessed for delirium. And in the first study by Mentis, the prevalence there was 14%, and the second study by Cachon, the incidence was 33%. Now we're going to discuss some of the risk factors for developing delirium. The first one is having underlying dementia, recent surgery, any dehydration or kidney dysfunction, polypharmacy, and older age. In a study published in the Archives of Internal Medicine, a review over 80 studies were done that looked at the incidence of delirium with different types of surgeries. As you can see, with patients that develop orthopedic procedures, the incidence of delirium was 28 to 53%. Patients that had open heart surgery, the incidence was 17 to 74%. And in neurological studies, there was a lower incidence of 4.5 to 6.8%. Interestingly, the type of anesthesia that was used did not lead to any better or worsening of the delirium. A study published in the American Journal of Medicine that looked at intraoperative factors that led to delirium after surgery. It was noted that the presence of low blood pressure, fast heart rate, and slow heart rate increased the incidence of delirium postoperatively. The fast heart rate was considered 120 beats per minute in 5 minutes or more. A slow heart rate was less than 60, and a low blood pressure was systolic blood pressure less than 90. In this slide, you noticed the several factors in the association of intraoperative factors with the development of post-op delirium. If the patient had a hematocrit below 30%, there was an increased odd ratio developing delirium by 1.7. Age, cognitive impairment, poor physical function, history of alcohol abuse, abnormalities in chemistry such as hyponatremia, and abdominal aortic aneurysm surgery. What are some of the screening tools that we have? The main one that's used in the inpatient setting within the hospital ward or the ICU is the CAM method, or the ICAM, which is the ICU form. There's also the DSM and the MDS that's used in the nursing home. As you can see, the CAM is sensitive 94 to 100%, and specificity is 90 to 94%. The MDS that's used in the nursing home setting has not been validated. We're going to now review our mnemonic that we talked about in the beginning of the lecture, the delirium's mnemonic. As you can see, with multitude of medications that can cause delirium and different classes of drugs, such as anti-Parkinsonian medications, corticosteroids such as prednisone that commonly can cause psychosis and agitation, medicines to treat overactive bladder such as oxybutynin, methylxanthine such as theophylline, when drug levels are up, can cause confusion. Drugs that improve gut motility such as metoclopramide, cardiovascular drugs, H2 blockers such as ranitidine or famotidine that are antihistamines such as Benadryl. Antibiotics have been shown to cause change in mental status, most commonly ceftriaxone that can cause hypoalertness, narcotics that also can cause sedation, geriatric psychiatric medicines such as antipsychotics and sedatives that can cause change in mental status, the ear, nose, and throat medicines, again the antihistamines for allergic rhinitis, medicines for sleep. NSAIDs have been shown to cause hypoalertness. muscle relaxers have been shown to cause muscle or hypoalertness, and then seizure medications such as Dilatin or Keppra that are commonly used. Any medication can cause mental status changes. Now, there's a syndrome that's been described in the literature called cardiocerebral syndrome, in which either a myocardial infarction has been shown to lead to delirium. Foley catheters have been shown to be a major cause of delirium. They're typically inserted in the emergency room setting or to monitor eyes and nose on the cardiology floor, patients after a stroke, or in the ICU setting. In the typical medical floor, patients that come from the ER with Foley catheters, it has been shown in an observational study that many of the students, residents, fellows, and physicians were unaware that the patient had a Foley catheter in place. The detriment from a Foley catheter is infections leading to bacteremia, as well as urinary retention once they're removed. If you look at outcomes and numbers from a catheter being placed, if the incidence of catheter placement at the hospital is 25%, with the incidence of bacteriuria being 26%, probability of developing UTI is 24%, and bacteremia 3.6%, then the probability of death is 31%. In a hospital that has 16,000 admissions per year with a 25% placement of Foley catheters, you will have 13 patients dying as a result of a catheter being put in. Whereas if the incidence of placement is dropped to 5%, then only 2.3 patients will die, thus saving the lives of 10 to 12 patients. Clinical pearl is tried to avoid placing them in the first place and then remove them as fast as possible prior to discharge. As previously discussed, infections are a common cause of delirium. Commonly missed infections are cholecystitis, diverticulitis, and dental abscesses. Urinary retention is very common and can just present from debility and laying in bed in the nursing home or the hospital setting, and is a very common cause of delirium. Fecal retention is also a very common cause of delirium that is commonly missed. Next, we're going to discuss epilepsy and delirium. As you can see, the incidence of epilepsy increases with aging. The incidence is as common as Alzheimer's dementia. It is very commonly delayed in diagnosis. A multitude of times it's suspected the patient has had a stroke. The types of epilepsy that are seen can range from anywhere from complex partial to simple to tonic-clonic and mixed seizures. Very commonly, patients present with delirium from dehydration and malnutrition. Many patients take loop diuretics or thiazide diuretics for their blood pressure or heart failure or pedal edema that can lead to dehydration and delirium. Many patients are placed on heart-healthy diets or diabetic diets, which are not placed or used in the nursing home settings. Typically, we use regular diet with no concentrated sweets or regular diet with no added salt in the nursing home setting. And these therapeutic diets usually lead to weight and malnutrition and delirium in these elderly patients. We're going to now discuss how to manage these patients with delirium. Most importantly, be aware that you should treat the underlying cause first, whether it's dehydration, malnutrition, electrolyte disturbances, retention, infection, heart failure. Treat the underlying cause, and many of your patients will get better. In the meantime, avoid restraints. If you need to use sedatives, use them with caution. Be aware that they're not FDA approved for the treatment of delirium. Several studies have looked at Haldol, quetiapine, Zyprexa, risperidol. None of these studies have been placebo-controlled. There's been some minimal improvement. If you have to use these medications, use them short-term and stop them as soon as the underlying cause of delirium has resolved. Find that the elderly metabolize drugs differently through the liver and the kidneys, and many drugs such as beta blockers that are excreted by the kidneys will build up and cause hypertension, bradycardia. Also, quinolones that are removed by the kidneys, you have to reduce their dosages, and as such, then they're more prone to develop side effects, particularly with the antipsychotics because they affect many receptors. Just remember the simple rules for prescribing antipsychotics. Do not use them routinely. Use them at low dosages. On many occasions, clinicians will give 5 milligrams of Haldol as opposed to a half a milligram of Haldol, and keep the patient as alert as possible in their hospital room or nursing home room to lessen further worsening of delirium. Keep in mind that delirium rooms lessen the deterioration and function of a lot of our patients. They're restraint-free rooms. They lessen the chance that you will use sedatives. You could use bright lights, sound to help these patients while they're in the hospital. You can order physical therapy to help them mobilize as soon as possible. Keep in mind again that with delirium, it is a sudden change in consciousness, acute onset, that can fluctuate with disorganized thought process and clouded attention. The sooner you make the diagnosis of delirium, the better outcome your patient will have.